COPD is cardiovascular. Now, intuitively, all of us think that COPD patients usually die of respiratory failure. But the actual fact is, more patients with COPD die of heart disease than respiratory failure. And over half of COPD patients die from cardiovascular disease. Now, there are a lot of studies, and one of is, of course, the huge Framingham database, which looks at vital capacity as a predictor of cardiovascular disease. And the Framingham study showed that the lower the vital capacity, even if you correct for other cardiovascular risk factors, the higher is the cardiovascular mortality. So low vital capacity indicates a high risk of cardiac disease. And this is even after you correct for smoking, you correct for hypertension, you correct for diabetes, all those factors you correct. And you can see that the annual incidence of cardiovascular mortality is higher as is the reduction in vital capacity. So if your vital capacity is lower by about 17 to 18%, you have a higher mortality in terms of heart disease. The lung function is also a predictor many times of myocardial infarction and such risk factors. And this may be the mechanism which has been proposed is that COPD is a disease which is an inflammatory disease. And people have looked at the C-reactive protein levels across populations in COPD and have found that the CRP levels in patients with COPD is higher than in controls as a group. And C-reactive protein is a marker of inflammation. And inflammation leads to increased atherogenesis. And this is what leads to increased cardiovascular and even cerebrovascular mortality. And also other cardiovascular diseases, for example, hypertension. So ventilatory function is a predictor of fatal stroke. The other small issue of COPD is that many times we use the term interchangeably with asthma. And I think it's many times important to classify it correctly whether somebody has COPD or has asthma. I see lots and lots of patients who are sort of called, one is called the other. And of course, sometimes the diagnosis can be pretty difficult to make. You can't always differentiate COPD from asthma. But there are certain important differences. There is a difference in cause. Asthma is predominantly an atopic disease, whereas COPD is a disease usually caused by smoking. In asthma, you use inhaled corticosteroids very early in the disease, whereas in COPD, you use bronchodilators first and not asthma. Asthma responds far more dramatically to treatment, unless it is chronic severe asthma, which essentially behaves like COPD. Whereas COPD in the vast majority of patients responds partially and not dramatically to any form of therapy. So we think of asthma how do you make this diagnosis of asthma and COPD? Usually patients may have had symptoms during childhood, and then they might have got better and then again become symptomatic in adulthood. There's many times a family history of atopy. So you don't ask whether somebody else in your family has asthma straight away. They may have other atopic disease, so symptoms of allergic rhinitis, symptoms of skin disease. There is very good response in asthma to steroid bursts. So if you use inhaled corticosteroids for a week or 2 weeks, oral corticosteroids, you get a very good result. Many times these patients are non-smoker, and there is more pronounced wheezing in asthma than in COPD patients. You think of COPD when the onset of symptoms start later in life. If somebody is 30 years old or 35 years old, it's very, very, very unlikely that they have COPD. That is asthma. Because even if they start smoking at the age of 17, 18, 16, it will take at least 25, 30 years to develop COPD. Many times there is no family history of atopy. The response to steroid burst is not very dramatic. Most of them have been smokers or are smokers, and there is not much wheeze. There may be prolonged expiration and there may be diminished breath sounds, but the wheeze is not very dominant in a lot of patients with COPD. However, you're still left with a proportion of patients where it is very difficult to say whether they have COPD and asthma. So how should you manage these patients whom you're not sure? If you're not sure whether somebody has COPD or asthma, they should always be managed like an asthmatic. That means they should have inhaled corticosteroids. and inhaled bronchodilators. So in a patient whom you are not sure of, it's best to treat them as an asthmatic. So I think with this I would like to end, and thank you very much for a very patient hearing, and if you have any comments or questions, please feel free.